Emeritus Chairperson, sir, Dr. M.ch Resident, sir, Vice Chancellor, Dr. Agrawal, sir, and Dr. V.K. Kapoor, sir, Pro Vice Chancellor, MGUMST, Dr. Sarna, sir, Convener of M, and all my respected senior faculties and my fellow colleagues. Today we are on the occasion of 33rd PGCR on the topic Understanding and the Classification of Hormones. So these are the subtopics we are going to discuss today. I am Dr. Gupil Pattrick, first year resident, Department of Physiology, presenting you topic Introduction and Classification of Hormones. This presentation is made under the guidance of Dr. Aparna. This presentation is made under the guidance of Dr. Aparna Gar, Professor and Head, Department of Physiology, and under moderatorship of Dr. Himanshu Gupta, Assistant Professor, Department of Physiology. So the very first term arises, what is hormone? Actually hormone, it is a word derived from a Greek word that is hormone, and it means to excite. So these hormones are the organic molecules which are synthesized by endocrine glands and in response to a specific stimuli and exert their precise effect on particular target cells. So here are some pioneers in the field of hormonology. So starting from Dr. Ernst Sterling, he coined the term hormone all the way from 1956. Now hormones, there are certain characteristics. They first of all produced by a specific set of glands, endocrine glands. They are secreted into the bloodstream. Then they travel to the target cell, which may be close or far away from point of secretion. Target cells are conferred with receptors that are specific in their affinity or the binding capacity for the hormones. They act in low concentration, but their effect is long lasting. Hormones show high degree of specificity. Now what are target cells? Target cells refer to the cells that contain specific receptor for specific hormones. Once a hormone binds to the receptor, a chain of events is started on the target cell that unfolds and eventually impact gene expression and protein synthesis. Now hormone receptors, which are the binding sites on the target cells, they are activated only by the hormones. They have certain properties. They are the properties of the receptors. Their location, specificity, their affinity, receptor capacity and receptor number. Now receptor number, this can be upregulated and downregulated depending on the concentration of the hormone present in the body. In the upregulation, the number of receptor will increase, and in the downregulation, they will decrease by the feedback. Now after the hormone has exerted its function to the specific target cells, they are removed, they are degraded, they are removed from the body. Basically either by the binding with the tissue receptors, by the metabolic destruction of the tissues, they are excreted by liver into the bile, or through urine by kidneys. Now we have classified hormones. This is on 4 types. On the chemical nature, how they act, mechanism of action, based on mode of secretion and based on function. Now very first, based on chemical nature. These are peptide or protein hormones. First type. These are water soluble, so they will act via membrane receptors. Example include ADH, oxytocin, ACTH, prolactin and PTH. Second type are the steroid hormone. They act via intracellular receptors. They are lipid soluble, and example include cortisol, aldosterone and sexestrogen. Lastly, we have amino acid derivative hormones. They are further classified into water soluble and lipid soluble. Water soluble amino acid derivative hormones are catecholamines, serotonin and histamine. Lipids are thyroid hormones. Secondly, we have classified hormones on the mechanism of action. Mechanism of action can broadly be divided on 2 types. Firstly, by the use of second messengers that help in the signal transduction. Example include CAMP, CGMP, and they are membrane receptor water soluble, and hormones act through by this mechanism include ACTH, ADH, insulin through tyrosine kinase. And second, we have through gene activation. They use intracellular receptors. They are lipid solubles. An example include steroid and thyroid. Thirdly, we have classified hormones on the basis of mode of secretion. They are further sub-classified into 5 types. The very first is endocrine. These act on distant organs, example include thyroid. Second type of classification is paracline cell. They act on nearby cells, example include prostaglandins. Third is autocrine cell, that is they act on the same cells, example is growth factor, they increase the growth of the cell. Fourth is neuroendocrine, they are secreted by the neurons itself, and example include APS. Fifthly, we have signaling through gap junction, through the modulation of the gap junction, example include oxytocin. Fourthly, we have classified hormones on the basis of function. They are tropic hormones and non-tropic hormones. Tropic hormones are the ones which act on other endocrine glands, example TSH, ACTH, and non-tropic hormones include insulin and GS. They act on target tissues. Now I would like to invite Dr. Tushtika, second year, for the further elaboration of the book.
Secretion and regulation of the hormones. We'll start with the general mechanism of hormone secretion. It has 4 stages, starting with the synthesis. There is transcription and translation. Then it is packaged and stored in the endoplasmic reticulum and Golgi bodies. Here they are stored in the vesicles, and on the stimulus like the calcium ions and the CAMP, they get triggered, and via exocytosis they release into the bloodstream, forming the receptor binding and cellular response. Regulation of hormone is done via 4 mechanisms: neural regulation, humoral regulation, feedback regulation, and chronobiological regulation. We'll be discussing this one by one. Coming to first, which is the neural regulation. Under the neural stimulus, there is activation of the autonomic nervous system, leading to the endocrine gland secretion and hormone secretion. The simplest example is the sympathetic stimulation that stimulates the adrenal medulla gland, leading to the adrenaline release. Coming to the humoral regulation, this works on the principle of restoration of homeostasis. Endocrine cell senses the change in the blood ion concentration, leading to the hormone secretion, thus correcting the blood levels. Examples are the pancreatic hormones, that is the insulin and glucagon, balancing the blood glucose level, and the plasma calcium level is balanced by the parathyroid hormone. Now the feedback mechanism. The feedback regulation, to understand this, we have to first go through the hypothalamic pituitary axis. In this diagram, there is a hypothalamus which serves as the master gland, which secretes all the...
This is not master gland, this is the master controller. Master gland is anti-reproductive. Master controller, master regulator,
So it acts as a master regulator where all the releasing hormones are secreted from here, like the gonadotropin releasing hormone, the thyrotropin releasing hormone, and the corticotropin releasing hormone.
Can you tell me the anatomy and main nuclei which are and functions of hypothalamus?
So hypothalamus is between the corpus callosum. Below the corpus callosum and the thalamus, there comes the hypothalamus. And here they have nuclei like the supraventricular, the paraventricular.
पहले तो boundaries बताओ hypothalamus.
Above it is by the corpus callosum.
ऊपर होगा ना hypothalamus.
Thalamus ऊपर होगा and then the hypothalamus.
What is the size of hypothalamus? Just like almond size. It's a very thin layer of the gray matter cells, and it surrounds the lateral or third ventricle, floor of third ventricle, part of third ventricle. That is the key part. You can go from median to lateral side or from posterior to median to posterior side. कौन से important nucleus जो often describe?
So we have paraventricular nucleus, supraventricular nucleus.
सबसे important कौन है जो आपकी slide में दिखाई?
So paraventricular में arcuate.
Arcuate is very important for the thyroid, for the adrenal cortex, for the gonadotropin releasing hormone. They are all governed by. What are the 3 main functions of hypothalamus?
So it relays all the releasing hormones and that.
ये तो एक फंक्शन हो गया एंडोक्राइन. बाकी क्या फंक्शन है? बॉडी का टेम्परेचर भी रेगुलेट करती है और भी कुछ. कैसे डिवाइड करोगे?
Because it has afferents coming from all the reticular system, limbic system, so it controls the behavior.
I want to answer in broad categories. You know or not? Concept clear नहीं. एक इनका hypothalamus का फंक्शन होता है endocrine फंक्शन, regulation of the endocrine function. दूसरा होता है regulation of the autonomic nervous system. तीसरा होता है regulation of the limbic system, which is responsible for emotions, memory, behavior, including psychology. That is very important. hypothalamus is very important structure, though it weighs only 1 to 2 gram, maximum 4 gram. Okay? But functions, controls the autonomic, both sympathetic and parasympathetic. It controls the behavior, memory, and it controls the endocrine system. Arcuate, nucleus, and paravector, even the circadian rhythm, is all controlled by the तीन फंक्शन इसको ट्रायंगल की तरह बना लो, एक लिम्बिक सिस्टम, एक ऑटोनॉमिक नर्वस सिस्टम, एक एंडोक्राइन रेगुलेशन. ये तीन इंपॉर्टेंट फंक्शन है जो आपको हमेशा याद रहना चाहिए.
Then comes the anterior pituitary and the posterior pituitary. The posterior pituitary has secretion and storage of the ADH and the oxytocin hormone, which is synthesized in the supraventricular nuclei in the hypothalamus.
Difference in anterior pituitary and posterior pituitary. Embryological difference.
So the anterior pituitary is the posterior pituitary is the neuro part of this thing, and the anterior pituitary has the endocrine cells mostly. So it has.
The origin कहाँ से होता है? embryonic development कहाँ से होता है?
The corpus.
Rathke's pouch.
Rathke's pouch.
Rathke's pouch is responsible for anterior pituitary.
And the continuation of the neural part is from the posterior.
So that is diencephalon. Extension है. Neural brain का part है posterior pituitary. और olfactory bulb Rathke's pouch का part है anterior. उसी के हिसाब से आपको ट्यूमर्स हैं, बाकी जो पैथोलॉजी आएंगी, सिंड्रोम्स आएंगे, जैसे कालमैन सिंड्रोम होता है, जिसमें फेलियर ऑफ माइग्रेशन ऑफ न्यूरोएंडोक्राइन सेल्स, वो आप इसी से एक्सप्लेन कर सकते हो दैट इफ यू नो दी एम्ब्रियोलॉजिकल पार्ट ऑफ द एंटीरियर पिट्यूटरी एंड पोस्टीरियर.
Then we have all the stimulating hormones coming from the anterior pituitary, the thyroid stimulating hormone, the follicular stimulating hormone, which act on the respective glands to release the hormone at the target cell level and cause the physiological response. The feedback regulation. The feedback regulation occurs in two mechanisms, the loop mechanism. To understand this, there is a one long loop. Here the cortisol gives negative feedback or positive feedback to the hypothalamus. In the short loop, it can give the positive or negative feedback to the anterior pituitary or the hypothalamus. But in the ultra short loop, we have the tropic hormone which inhibits itself by inhibiting its release. That is through the anterior pituitary. Positive feedback mechanism. Here, the positive feedback mechanism, we have the initial response secretion is done by the amplification of hormone release, and it ceases when there is completion of the physiological event. Example is oxytocin release during parturition. And coming to the negative feedback mechanism, there is an increase in the parental hormone level which inhibits the hypothalamic releasing and the pituitary stimulating hormone while stabilizing the hormone levels. This acts by the thyroxine inhibiting both the stimulating and the releasing hormone.
It is applicable not only to one hormone, it is for all.
All the negative.
ठीक है, ये थायराइड के लिए भी है, ये एड्रिनल कोर्टेक्स के लिए भी है, ये and both hormones.
Coming to the understanding of chronobiological control of hormones. Here the suprachiasmatic nucleus comes into play, which acts as a master clock that controls the rhythmic patterns of certain hormones. There are oscillating and pulsatile release of certain hormones, which works on the diurnal seasonal variations. Like due to sleep-wake cycle, there is variation in the levels of cortisol seen. It acts as an auto-regulatory feedback mechanism, leading to rhythmic hormone levels by inhibiting their production and thus maintaining the normal circadian rhythm of the human body.
Good morning, all respected dignitaries, my seniors and my colleague. I am Dr. Pragya Jain from Department of Physiology, and today I will discuss mechanism of action of hormones. So these are the basic steps of the hormone action. Hormone first bind with its receptor, then there is formation of hormone receptor complex. This activates signal generating mechanism, and lastly there is physiological response in the cell. In this picture we can see that the mechanism of non-lipid soluble, water soluble hormone, how they bind. So they cannot directly diffuse in the cell membrane. So first there is activation of G protein that leads to activation of adenyl cyclase, and it causes release of second messenger, and ultimately there is physiological response. And the other one is lipid soluble hormone. They can directly diffuse in the cell membrane and they go to the cytoplasm nucleus and then occurs transcription and translation.
These are two fundamental differences. All the resident must know about it. जो water soluble trophic hormones है, ठीक है ना? They are the glucopeptide, long chain, ठीक है ना? And they are large apart from the water solubles. So they cannot cross the cell membranes. So they have to act on the cell surface. But the steroids, thyroid, they are the lipid soluble. They can directly go into the nucleus. So all steroid hormones or thyroid hormones, they act on the nucleus, directly on the nucleus. The rest of the hormones, gonadotropin hormone, releasing hormones, or ACTH or thyroid, they act through, growth hormone, they act through the surface. Okay? Because they are large and they are water soluble. They cannot cross the cell surface. This is fundamental difference, which all of you should know.
So here are the mechanism of signal transduction pathway. There are 4 mechanisms. First is activation through second messenger. Second is through intracellular or membrane enzyme activation. Third is activation of ion channel. Fourth is through activation of transcription process. So first is through second messenger. So as we know, hormones are first messenger and second messengers are the intracellular signals that are formed after the formation of hormone receptor complex, and the release of second messenger is mediated by G protein. As we can see in this picture, first G protein are activated and then they release second messengers like CAMP, CGMP, calcium and others, and ultimately they cause physiological response in the cell. So mechanism of action through second messenger, the first there is activation of G protein as we can see in this picture. Then this leads to activation of adenyl cyclase. So there occurs CAMP mechanism, and example of this mechanism is FSH-LH. Second is through activation of guanyl cyclase. This is cyclic GMP system, and example is atrial natriuretic peptide and nitric oxide. Third is activation of cell membrane phospholipids that include inositol triphosphate and diacylglycerol. Example of this mechanism is oxytocin, growth hormone, releasing hormone, and fourth is calcium comedylin system. In this, acetylcholine and oxytocin work by this mechanism. Second is mechanism of action through intracellular or membrane enzyme. It has 2 subtypes. One that have tyrosine kinase activity, example insulin, and the others which do not have intrinsic tyrosine kinase activity, example is growth hormone. Third mechanism is through action through ion link channel receptors. These channels may be calcium or sodium ion. And fourth is mechanism of action through activation of gene. So example of thyroid and steroid, they directly go to the cytoplasm and nucleus, and there occurs transcription, translation. So this was all about the mechanism of action. Now I would like to call Dr. Sumegha from Department of Endocrinology for further discussion.
Good morning to all the esteemed dignitaries, faculty and my dear colleagues. I am Dr. Sumegha from Department of Endocrinology, and this presentation will briefly cover the physiological basis of major endocrine hormones and their clinical relevance. So coming to the pituitary gland is the master gland of the endocrine system. It has 2 parts, anterior pituitary and posterior pituitary. Anterior pituitary secretes growth hormone, thyroid stimulating hormone, adrenocorticotropic hormone, LH, FSH and prolactin. These regulate growth, thyroid, adrenal, gonadal function and lactation. And the posterior pituitary releases ADH and oxytocin. ADH acts on kidney for water reabsorption and oxytocin causes uterine contractions and milk ejection. So overall pituitary controls multiple endocrine organs through its hormones. Now coming to the first hormone, master gland of endocrine system. Now coming to the first hormone, growth hormone, which is secreted by the anterior pituitary. The release of growth hormone is stimulated by growth hormone releasing hormone and inhibited by somatostatin. It acts both directly and via IGF-1 produced from the liver. It promotes linear growth, protein synthesis, lipolysis, raises the blood sugar levels, and also helps in tissue growth and proliferation. Now coming to the abnormalities associated with growth hormone. Growth hormone excess leads to characteristic clinical features, most commonly acromegaly in adults. So these changes are due to prolonged exposure to growth hormone and IGF-1. We see acral enlargement, coarse facial features, and significant metabolic effects like insulin resistance. In addition, there are cardiovascular, respiratory, and musculoskeletal complications. Now coming to the images, the face shows coarse facial features with soft tissue thickening, which is typical of acromegaly. The hand and foot images, they demonstrate acral enlargement with increased size and soft tissue thickening compared to normal. Now coming to growth hormone deficiency, it mainly presents with short stature and reduced growth velocity in children along with delayed bone age. There is increased fat mass and reduced lean mass leading to fatigue and decreased muscle strength. The first image shows a family of proportionate short stature, which is typical of growth hormone deficiency, and the second image demonstrates height measurement using a stadiometer. Now we come to the next hormone, which is ACTH. It is released from the anterior pituitary, which in turn acts on the gonads to release, which in turn leads to the release of cortisol from adrenals. Cortisol increases blood glucose, causes protein breakdown, fat redistribution, suppresses immunity, and helps to maintain blood pressure. Now the abnormalities associated with cortisol hormone. Cortisol excess causes Cushing syndrome, and deficiency of cortisol leads to adrenal insufficiency, which can be primary adrenal insufficiency or secondary adrenal insufficiency. Now coming to Cushing syndrome. Cushing syndrome is due to excess cortisol, which can be either ACTH dependent or ACTH independent. Clinically, it presents with central obesity, moon phases, and characteristic purple stria. Patients may develop proximal muscle weakness, hypertension, hyperglycemia, skin thinning, osteoporosis, and reproductive dysfunction. Here the facial image shows moon phases due to fat redistribution and vascular changes. The abdominal image shows wide violaceous purple stria, which occurs due to skin thinning and collagen breakdown. Now next we come to primary adrenal insufficiency.
How will you differentiate ACTH dependent caused, whether it is pituitary, Cushing disease, or ectopic ACTH? Producing tumor.
So there are multiple levels to it. First of all,
gold standard which we are doing in your department regularly.
Sir, first of all, clinically, IPSS is the gold standard to differentiate dependent
inferior petrosal sinus sampling bilateral.
Yes, sir.
Sir, what is the ratio? How will you differentiate K-pituitary से ACTH secrete हो रहा है या ectopic से
So IPS is to central to peripheral ratio. Stimulated should be more than 3.
What should be the ratio?
More than 3. Stimulated ratio should be more than 3.
To say whether it is
Central.
Central.
Yes, sir.
Or ectopic. You can differentiate that. Yeah?
Yes, sir.
And when will you order that?
Sir, we order it when we have we are not able to decide whether it is central or ectopic after we have done the clinical as well as the biochemical workup with the dynamic tests as well as the.
कैसे करते हैं इसको?
IPSS, sir. Sir, first of all, we on the
रेडियोलॉजी वाले होते होंगे ना साथ में? पता है? हाँ. तो बताओ. Very important. This is very rare test which is done in very few institutions. We are lucky. We are doing this.
So, as sir has mentioned, it's probably being done almost not more than 6 or 7 centers. Most of them are INIs or the very old reputed medical colleges. So, and we are doing it in our institute from 2015 onwards. What we do is, of course, it's a combined team job of neurointervention radiologist as well as endocrinologist. So, we enter through femoral vein and go up to the inferior petrosal sinus up near the pituitary, because the idea is to get the level of ACTH nearer to the source, which is supposed to be the most common cause of Cushing's, that is pituitary. So we go enter into the IPS, both sides from right and left, and then we compare the ACTH level at inferior petrocell sinus with the peripheral ACTH. The test can be done in unstimulated form, then the cutoff or the gradient is 2:1. That means that IPS ACTH level should be twice high than the peripheral ACTH to say that the source is pituitary indeed or not. Or if we do stimulated, initially we used to do with CRH, which is now not available so much in world. In fact, everywhere there is a problem. So we use another stimulant, what we called as poor man's CRH, that is vasopressin, which again act on through the V1B receptor. So CRH act through the CRH receptor on the pituitary, and vasopressin act on the vasopressin 1B receptor, which is again expressed on the corticotropinoma, leads to stimulation, leads to ACTH synthesis. And again, so the stimulation is more than 3:1, that is how we do it. The most important thing is that we need to ensure that we are in pituitary, we are in IPS. That's the most critical step, where we have made it a rule that our neurointervention radiologist, whenever they say that we are in IPS, we do some biochemical tests like prolactin and make sure that we have collected the correct sample. Because that is the thing which is going to decide whether you are dealing with the central or peripheral. If we are not in right position, we will always get no gradient and it will be labeled as an ectopic, and we'll keep on searching ectopic and we will never find it. So that is why it's a very integrated so-called job where both needs to trust each other and very good communication should be there. So that's something which I think our institute had done quite a lot, and we have a good experience about it.
Now coming to primary adrenal insufficiency, it presents with fatigue, weight loss and hypotension. A key distinguishing feature is hyperpigmentation, which is seen over knuckles, palmar creases, oral mucosa due to elevated ACTH. Gastrointestinal symptoms like nausea, vomiting and abdominal pain are very common. Electrolyte abnormalities like hyponatremia, hyperkalemia along with hypoglycemia, and patients can also present with salt craving and muscle pains. Here the images highlight hyperpigmentation in nails, palms, tongue, knuckles and pressure areas, which is characteristic of primary adrenal insufficiency. Coming
एडिसन्स डिजीज और सेम भी होते हैं अलग अलग?
सेम
एक्वायर्ड और उसका कंजेनिटल का फर्क होता है क्या?
So primary adrenal insufficiency is called as Addison's disease, and depend on the etiology. Like it's basically primary adrenal insufficiency. In Western world, the most common cause is autoimmune. In Indians, in developing country, it is the most common cause, so-called is tubercular. However, the spectrum is now changing. So, but primary adrenal is called as Addison's disease, and when we have a crisis, then it's called as Addisonian crisis. And generally, crises are seen in.
Now coming to the next hormone, prolactin. Prolactin is under tonic inhibition by dopamine from hypothalamus. Decrease in dopamine leads to increase in prolactin. Prolactin also suppresses gonadotropin releasing hormone, which leads to decrease in LH and FSH, which in turn inhibits ovulation in females and reduces spermatogenesis and testosterone in males. So hyperprolactinemia presents in females with amenorrhea, oligomenorrhea, galactorrhea and infertility, in males with reduced libido, erectile dysfunction, infertility and gynecomastia. Next, coming to LH and FSH. Now this diagram shows the HPG axis. The gonadotropin releasing hormone stimulates LH and FSH, which acts on the gonads to produce sex steroids with negative feedback. Luteinizing hormone drives testosterone production in males and ovulation and progesterone in females. FSH regulates spermatogenesis via the Sertoli cells and follicular growth, and estrogen production via the granulosa cells. Testosterone promotes spermatogenesis, libido, secondary sexual characteristics, and has anabolic effects on muscle and bone. Now coming to disorders related to LH and FSH is hypogonadism. It can be classified as primary or secondary. Primary is due to gonadal failure, that is low sex hormones with high LH and FSH, which is hypergonadotropic hypogonadism, and secondary is due to hypothalamic or pituitary defect, which is low FSH and LH with low sex hormones. Now this slide, it shows, it is about primary hypogonadism, which is hypergonadotropic hypogonadism. A classical example is Turner syndrome. In the left image you can see increased carrying angle, cubitus valgus, which is a typical skeletal feature of Turner's. In the center we can see webbed neck and sandal gap deformity, which is another physical marker. Next is secondary hypogonadism. It is due to hypothalamic pituitary dysfunction. Classical example is Coleman syndrome. In this image we can see a 25-year-old male with unicoid body habitus and sparse secondary sexual characters. The genital image shows small testicular volume, bilaterally around 4 cc, which is significantly reduced for age and indicates impaired gonadotropin stimulation. Next.
Coleman syndrome ऐसा है जो almost all type of inheritances are there. Autosomal dominant, autosomal recessive, X-linked, everything is there. So you have to go for multiple gene identification, alright? And there is a test developed by the Pennsylvania University for the detection of the smell. So.
Now ADH is synthesized in hypothalamus, mainly the supraoptic nucleus, and released from posterior pituitary. The major stimulus for release is increased plasma osmolality and low blood volume or blood pressure. It acts at the kidney via the V2 receptors and increases water reabsorption in the collecting duct leading to formation of concentrated urine. Coming to abnormalities of ADH, ADH deficiency causes a condition called diabetes insipidus. Reduce in ADH causes polyuria, dilute urine, low urine osmolality, increased serum osmolality and hypernatremia. ADH excess causes SIADH, which causes water retention, concentrated urine, decreased serum osmolality and hyponatremia. Now thyroid gland is regulated by the HPT axis. TRH is released from hypothalamus, which acts on the pituitary to release TSH, leading to the release of T3 and T4. The functions of thyroid hormone can be increases basal metabolic rate, increases blood sugars, increases lipid breakdown, is essential for brain maturation and bone growth, and enhances beta adrenergic activity in the heart, increasing the heart rate and cardiac output. Now coming to hypothyroidism. Hypothyroidism.
Can you tell me any organ in the body which has got the highest blood supply per gram of the tissue?
Highest blood supply per gram of thyroid.
What is the weight of thyroid gland? And where it is situated?
8 grams. 8 to 10.
15 to 20 ग्राम, ठीक है? और कहाँ सिचुएटेड होती है? रोजाना देखते हो, क्वार्टर में आते रहते हैं। C2 to C4 है।
C2
ट्रैक के बाद, ठीक है? पैराथायरॉइड की क्या पोजीशन होती है?
Sir, superior and inferior pole of thyroid. Posterior. Posterior.
ये आनी चाहिए ना, very important है। थायराइड के बिना तो बॉडी में कोई फंक्शन हो ही नहीं सकता, इसलिए ब्लड सप्लाई होती है। It involves almost all organs of the all systems of the body.
Hypothyroidism is due to failure at any level of HPT axis. Primary hypothyroidism, which is the most common, is due to thyroid gland dysfunction leading to low T3, T4 and high TSH. Secondary and tertiary causes involve the pituitary or hypothalamus, where TSH can be low or inappropriately normal. So overall pattern is elevated TSH with suppressed T3 and T4. Here we can see in the image that that hypothyroidism has presented with growth delay, course phases and developmental delay. Now coming to hyperthyroidism.
How will you differentiate the normal hypothyroidism with the Hashimoto's hypothyroidism?
Sir, anti-TPO antibodies. If we are getting a...
What will be the biochemical features? What will be the difference?
Biochemical features will be the same, sir. T3, T4 is low and TSH is high biochemically. And then we do the anti-TPO antibody. If it comes positive, then we can label it as Hashimoto's thyroiditis.
In iodine deficient areas or iodine sufficient areas?
Sufficient areas.
Can you explain further?
So the spectrum of hypothyroidism have changed over a period of time in India also. The classical description of goiter and hypothyroidism used to be related to iodine deficiency. That used to be the most common cause, but after the universal fortification of salt, the spectrum, the prevalence remained same. Actually, everyone was expecting that hypothyroidism will go down in terms of prevalence. In fact, it has actually increased. There are multiple reasons to it, but one of the reasons is that once the universal fortification happened, the iodine deficiency related hypothyroidism went down, but the autoimmunity related hypothyroidism actually increased. Again, there are multiple reasons, endocrine disruptor theory and so on. So, as of now, today we have a most common cause of hypothyroidism is actually autoimmune, not iodine deficiency. That's one thing, because that's the main question sometimes patients ask, that is not being described. And so we can do anti-thyroid antibody, that is anti-T2 antibody and anti-thyroglobulin antibodies. Both of them are positive, and it's called as Hashimoto thyroiditis. Or we should have a biopsy evidence of lymphocytic thyroiditis. So, but nobody do the biopsy because now we have a non-invasive blood test available. The important thing is once these tests are positive, most of them are permanently positive, so patients require lifelong replacement of thyroid hormone.
Very important is every person you try to. Manisha is sitting here, one of our residents from our own hospital. She had 2 or 3 miscarriages, and she was having hypothyroidism, but she was not tested for the TPO antibodies by the fertility specialist. When I asked specifically whether you have undergone TPO antibodies, then she said it is always high 2 to 3 times, but never treated. So, because अगर आपका थायराइड करेक्शन नहीं है तो ब्रेन के डेवलपमेंट डिसऑर्डर्स हो जाएंगे, फीटल डेवलपमेंट डिसऑर्डर्स हो जाएंगे, मिसकैरेजेस होंगे. All these things can be corrected if you take care of the pathology. क्योंकि आयोडीन तो सारे आयोडाइज साल्ट का है, इसलिए आयोडीन सफिशिएंट में TPO एंटीबॉडी और थायरोग्लोबुलिन एंटीबॉडी हमेशा देनी चाहिए. ठीक है. In spite of the normal TSH.
Yes, sir. Now, hyperthyroidism is a state of increased thyroid hormone with raised T3 and T4 and suppressed TSH. Most commonly, it is primary due to Graves' disease, toxic multiple goiter or adenoma. Secondary causes include TSH secreting pituitary adenoma, and tertiary causes are rare. So, here, the upper image shows a diffuse goiter indicating thyroid enlargement in hyperthyroidism, and the lower image shows eye signs, exophthalmos and lid retraction. These are characteristic of Graves' ophthalmopathy. Now coming to parathyroid hormone, it is the key regulator of calcium homeostasis. It acts on 3 major organs: bone, kidney and intestine. In bone, PTH increases calcium release. In the kidney, it increases calcium reabsorption and activates vitamin D. Activated vitamin D then acts on the intestine and then increases calcium absorption. So overall PTH increases serum calcium levels. Clinically, excess PTH can lead to hyperparathyroidism, presenting with bone pains, fractures, kidney stones and psychiatric symptoms. And deficiency will lead to hypoparathyroidism, causing hypocalcemia, tetany, prolonged QT and arrhythmias. Now coming to hyperparathyroidism, it can be of 3 types. In primary hyperparathyroidism, calcium is high, phosphorus is low due to autonomous PTH secretion. In secondary hyperpara, PTH is high with low or normal calcium and high phosphorus. It is commonly due to chronic kidney disease or vitamin D deficiency. In tertiary hyperparathyroidism, there is long-standing secondary disease leading to high PTH with high calcium. Clinically, they can cause bone pains, fractures, kidney stones. And here in the image, you can see a pathological fracture, and in the second image, we can see a classic salt and pepper skull. Coming to hypoparathyroidism, idiopathic Idiopathic hypoparathyroidism is hypocalcemia with low or inappropriately normal PTH with no identifiable cause. So low PTH leads to decreased calcium reabsorption, decreased vitamin D activation and reduced intestinal absorption, so biochemically low calcium and high phosphorus. Clinically, the patients will present with tetany, muscle cramps, positive Shostak and Trousseau sign, prolonged QT and arrhythmias. Here in the image, in the first image, we can see a positive Trousseau sign, and in the second image is of NCCT brain, where you can see basal ganglia calcification. Next, coming to endocrine pancreas. Endocrine pancreas consists of islets of Langerhans with different cell types. So beta cells, they form the majority and secrete insulin, which is the most important hormone. Insulin lowers the blood glucose by increasing glucose uptake in the muscle and adipose tissue. It promotes glycogen synthesis, lipogenesis, GLUT4, yes. Glucose uptake transporter.
Speak all, eh?
Yes.
Thank you.
It promotes glycogen synthesis, lipogenesis and protein synthesis, so overall it is an anabolic hormone. Alpha cells secrete glucagon and delta cells secrete somatostatin. Now coming to the abnormalities associated with insulin. So type 1 diabetes is a state of absolute insulin deficiency due to autoimmune destruction of beta cells. In insulin deficiency, there is decreased peripheral glucose uptake and increased hepatic glucose uptake, leading to hyperglycemia. At the same time, lack of insulin increases lipolysis, increasing free fatty acids, which are then converted to ketones, leading to diabetic ketoacidosis. So the key concept is loss of insulin's anabolic function, resulting in a catabolic state. In this image, you can see disproportionate weight loss and muscle wasting. And in the second image, we can see the use of a continuous glucose monitoring device, which is placed subcutaneously and provides real-time glucose readings. Now, insulin excess. So, insulinoma is a beta cell tumor causing unregulated insulin secretion even in the presence of hypoglycemia. And it presents fasting hypoglycemia is more pronounced than the postprandial. And here we can see in the first image, the axilla shows acanthosis nigricans indicating insulin resistance. In the second image, we can see multiple skin colored nodules over the abdomen, which are collagenomas. So now coming to GIT hormones. The GIT hormones help regulate digestion, but importantly they also control insulin secretion. The key hormones here are gastrin, CCK, secretin, GIP, GLP-1 and motilin. So we'll discuss more about the incretins. Incretins are the gut hormones which enhance insulin secretion after meals. The two main incretins are GIP from the K cells and GLP-1 from the L cells. They stimulate glucose-dependent insulin secretion. So GLP-1 is more important as it also suppresses glucagon, delays gastric emptying and increases satiety, leading to better glucose control and weight loss. So based on the incretin physiology, incretin-based therapies, they translate directly into powerful clinical tools for glycemic control and weight reduction. The key class here is GLP-1 receptor agonists like semaglutide. There are also dual incretin agonists like tirzepatide, and these drugs have led to significant HbA1c reduction along with major weight loss. So, and they also reduce cardiovascular risk. So GLP-1 based therapies are now the cornerstone and blockbuster molecules for weight loss and diabetes. Now I would like to call Dr. Nikita Agrawal to take the presentation forward.
Thank you, Dr. Sumegha. Good morning to all the dignitaries present, faculty members and my colleagues. Myself, Dr. Nikita Agrawal, second year PG resident from the Department of Pediatrics. I will be discussing the basics of common pediatric endocrinology disorders. We'll start with the growth disorders. Growth hormone, as we all know, is released from anterior pituitary and plays a major role in linear growth and maintaining body proportions of the child by lipolysis and protein synthesis. Some actions are of its own and some actions are mediated by IGF-1. Any abnormality in the hypothalamus and pituitary can lead to short stature. It can either be due to growth hormone deficiency or can be due to growth hormone insensitivity, in which the levels of growth hormone is high but there is decreased secretion of IGF-1. Coming to the clinical features of growth hormone, as we can see in this picture, he is a 10-year-old male child with height less than 100 centimeters, which corresponds to the height of a 3 to 4-year-old child and is less than 3rd percentile. Other coarse facial features are small immature faces, chubby cheeks and hypoplastic nasal bridge.
With some months of treatment with growth hormone replacement therapy, child has attained a good catch-up growth as plotted on the growth chart. The chart shows how puberty starts and how it is controlled at hypothalamus and pituitary levels. During the pre-pubertal or the juvenile phase, inhibitory neurotransmitters are dominant, resulting in the suppression of hypothalamus and GnRH pulses. But during the early pubertal phase, stimulatory neurotransmitters become dominant, and thus GnRH becomes pulsatile and leads to appearance of secondary sexual characteristics, which is the key event in the puberty. Precocious puberty is defined as onset of breast enlargement before the age of 8 years in females and testicular enlargement before the age of 9 years in males. It can either be due to central cause, which is the premature activation of HPG axis, or can be peripheral, which is due to excess sex steroids from the adrenal gonadal sources without HPG activation. The picture shows a 4-year-old female child with breast enlargement, which indicates precocity. In affected children, there is early epiphyseal fusion and advanced gonads leading to decreased final height. Timely diagnosis and management can help the child in attaining adequate final height. Delayed puberty is defined as no breast development by the age of 13 years or no menarche by age of 15 years in girls, and no testicular enlargement by the age of 14 years in boys. The most common cause is the constitutional cause. In the hypogonadotropic hypogonadism, the primary insult is in the hypothalamus or the pituitary, which leads to decreased LH and FSH secretion. In hypergonadotropic hypogonadism, the primary insult is on the gonads, which leads to decreased release of sex hormones, and as a compensatory mechanism, LH and FSH is increased. The classical example is Klinefelter syndrome in males and Turner syndrome in females. This picture shows a 16-year-old female child who came to OPD with complaints of short stature and absence of secondary sexual characteristics, along with typical clinical features of Turner syndrome like low posterior hairline, webbed neck and cubitus valgus. My message through this is that if any female comes with short stature and delayed puberty, after ruling out the most common causes like hypothyroidism, child should be evaluated for Turner syndrome by karyotyping. This picture is showing adrenal hormone synthesis from adrenal cortex, which is regulated by ACTH hormone from anterior pituitary. This complex pathway involves many enzymes. First hormone is aldosterone. Its normal physiological function is sodium retention, potassium excretion and maintaining BP. Next hormone is cortisol, which is essential for metabolic and various important cardiovascular effects. Some amount of sex steroids is also produced from zona reticularis layer of adrenal. In case of any enzyme deficiency, there will be defective synthesis of aldosterone, cortisol and sex steroids. Most common and clinically relevant enzyme deficiency is 21-alpha hydroxylase deficiency. Due to deficiency of this enzyme, there will be reduced aldosterone production, which will lead to hyponatremia, hyperkalemia and hypotension. There will be reduced cortisol production, which will lead to hypoglycemia. Due to 21-hydroxylase deficiency, these precursors will be shifted to the alternate pathway, leading to increased testosterone production, which will result in virilization of female genitalia and isosexual precocity in males. Coming to congenital adrenal hyperplasia, this is due to 21-hydroxylase deficiency. It presents with salt wasting. So what is salt wasting? Salt wasting is basically hyponatremia, hyperkalemia and hypotension as discussed before. Due to decreased cortisol and aldosterone, there will be compensatory increase in ACTH levels, resulting in hyperpigmentation and affected newborns.
परसेंटेज ऑफ दी 21 हाइड्रोक्सिलेज डेफिशिएंसी बता सकते हो आप? सॉल्ट वेस्टिंग में कितनी होती है, सिंपल विरलाइजिंग में कितनी होती है, नॉन क्लासिकल में कितनी?
Sir, salt wasting type is more common.
लीस्ट कॉमन, सब ट्राई नहीं कर पाते. नो आइडिया. If it is less than 1 to 2%, then it will be salt wasting. If it is between 5 to 10%, then it will be simple virilizing congenital adrenal hyperplasia. And if the deficiency is up to 20-25%, then it will be non-classical form of the congenital adrenal hyperplasia, which you see in fertility or infertility parents. Okay? यहाँ पे आप MGUMST genitalia. Deficiency in all is 21 hydroxylase, 90 to 95%. 5% में, 10% में 11 बीटा हाइड्रोक्सिलेज की डेफिशिएंसी हो सकती है, ठीक है ना? बट मेजॉरिटी इज दी and 21 hydroxylase deficiency, and it is the amount of the hydroxylase. Kitni deficiency, if it is very severe, 1 to 2%, then it will be salt based. If it is 5 to 10, simple virilizing, ambiguous genitalia. और उसके बाद फिर नॉन क्लासिकल 20 to 25%. ठीक है?
The criticality of salt wasting and the kind of mortality in mortality likely to be operate there. The newborn screening program is included in the selection.
Maintenance and restorers.
Yes.
Thyroid hormone physiology. Through hypothalamus, TRS is released with resulting release of TSH from pituitary, and T4 and T3 and T4 is released from thyroid gland. Any abnormality in hypothalamus or pituitary results in central or secondary hypothyroidism, whereas any abnormality in the thyroid gland itself results in primary hypothyroidism, which is more common cause in children. It can either be due to thyroid dysgenesis or dysharmoniogenesis. Congenital hypothyroidism is often asymptomatic at birth. Thus it should be universal to send a thyroid profile for all the newborn babies as per guidelines. In our center, we send a cord blood TSH sample for all the newborn babies. If any infant is coming with symptoms of hypothyroidism, we are already late in diagnosing, and even after treatment, neurological damage cannot be reversed. This picture shows a 3-month-old male with clinical features: puffy face, periorbital puffiness, macroglossia. It can also lead to developmental DNA and prolonged jaundice. After few months of thyroid replacement, there is a drastic change in the appearance of the baby. Acquired hypothyroidism, the most common cause is the autoimmune condition called as Hashimoto's thyroiditis. As you can see in the picture, she is a 10-year-old female child with sallow complexion, short stature, calf pseudohypertrophy, periorbital puffiness, and dry pore skin. Thyroxine replacement therapy can help in these patients too. As we all know, calcium and phosphorus are two essential minerals for normal bone health. Any deficiency of calcium and phosphorus can lead to defective bone mineralization, leading to rickets in children. Most common form of rickets is calcipenic, that is due to deficiency of calcium. PTH is an essential hormone to maintain the normal levels of calcium. Calcium deficiency can either be nutritional or can be due to hypoparathyroidism. A common feature of rickets are wrist widening, Wine's web deformity, frontal bossing, Harrison sulcus, and pot belly. After food intake, plasma glucose levels rises and glucose enters pancreatic B cell via glucoreceptors. This step is insulin independent. Inside the beta cells, closure of potassium channels and opening of calcium channels leads to insulin release. This leads to entry of glucose into target tissues via glucoreceptors. This step is insulin dependent. As a result, blood glucose level normalizes. In case of autoimmune pancreatic beta cell destruction, there is impaired insulin release resulting in hyperglycemia. Due to hyperglycemia, ongoing osmotic symptoms like polydipsia and polyuria is seen. In severe cases, it can also lead to dehydration and acidosis, which is termed as diabetic ketoacidosis, and it can be life-threatening. This child came to us in decay state, and firstly stabilization was done in ICU, and then was started on lifelong insulin therapy. Child is currently on continuous glucose monitoring and is doing absolutely fine. Now I would like to call Dr. Shubhi to take the presentation forward.
Good morning, respected dignitaries, faculty, and my dear colleagues. Myself, Dr. Shubhi Srivastava, M.ch Resident from the Department of Reproductive Medicine and Surgery. The HPG axis has already been discussed, so I'll just provide the details which have not been discussed yet. As we can see, the GnRH is released from the hypothalamus. It is a decapeptide which is secreted in a pulsatile manner every 60 to 90 minutes. It acts on the anterior pituitary to release LH and FSH, which acts on the ovary to release estrogen and progesterone, and on the testes to release testosterone. So all these estrogen, progesterone, testosterone, they provide negative feedback and regulate their own secretion. But one catch over here is that estrogen, when it is in lower amount, it provides a negative feedback. But when it is more than 200 picograms per ml for around 48 hours, it causes a positive feedback and causes LH surge. Now the ovarian and uterine cycle. As we know that FSH is released from the anterior pituitary, and from the anterior pituitary, when FSH is released, it causes the recruitment and growth of the follicles in the ovary. These secrete estrogen. Now we can see over here the rising estrogen. This acts on the endometrium, causing the regeneration and growth of the endometrium, which is the proliferative phase in the endometrium. Now when it is sustained high for a long time, it causes LH surge, which we can see over here, the rise in LH, which causes ovulation. resulting in the formation of corpus luteum, which secretes progesterone and estrogen. Now this progesterone acts on the endometrium, causing the secretory phase and preparation for implantation. So the both ovarian and uterine cycle work hand in hand. Now this males we have already discussed it, so I will not go in details. The HPG axis. Now the role of anti-Mullerian hormone, that is AMH. When there is a presence of AMH and testosterone in the males, it causes the regression of the Mullerian ducts which are needed for the formation of female internal genitalia. So in males, male internal genitalia takes place, while in females there is absence of AMH at the time of sexual differentiation. So there is maintenance of the Mullerian ducts and formation of female internal genitalia. Now the role of AMH is important in adults at the time of reproductive lifespan because they are secreted by the granulosa cells of preantral and small antral follicles, and they determine the ovarian reserve. So as the age of the female increases, there is a decline in the functional ovarian reserve, and thus there is a decline in the AMH. Now PCOS, the most common cause of anovulatory infertility. It is diagnosed by the Rotterdam criteria, which means that out of the three, that is oligo-ovulation or anovulation, biochemical or clinical hyperandrogenism, which can be in the form of hirsutism or acne, or PCO morphology on the uterus. Any two of these are present, then we diagnose it as PCOS. But important over here is that we need to exclude the other causes also before diagnosing it as PCOS. Once we have excluded other causes, then only diagnose it as PCOS. In the pathophysiology of PCOS, I will just discuss the basic things. It is a multifactorial disease, we all know. So in this, there is altered GnRH pulsatility, which causes preferential increase in the LH, which acts on the theca cells in the ovary to produce androgens, which causes inhibition of the follicular maturation, causing anovulation. And in obese females, there is increased amount of adipose tissue, which causes adipose tissue dysfunction, leading to hyperinsulinemia, which further deteriorates the situation by decreasing the sex hormone binding globulin and increasing the insulin-like growth factor, causing more of the androgens and resulting in hirsutism and acne. This has already been covered, I will not go in details. Now the placental hormones in pregnancy, just a brief overview that these are secreted just to maintain the pregnancy, support the growth of the fetus, and to prepare the mother for the parturition and lactation. We have estrogen, progesterone, human chorionic gonadotropin, relaxing placental growth hormone, and placental lactogen and kisspeptin. Now I would like to call Dr. Himanshu for the take-home message.
Good morning, respected senior faculty.
Shubhi is our resident, she is very good. She prepared my lecture also.
As of now, we understood the functioning of the major hormones and the association of their disorders due to their hyper or hyposecretion. The take-home message is hormone regulates homeostasis through precise signaling, because increase in a small amount or decrease in a small amount may cause a severe disease. Whenever there is a disturbance in the balance, either hyper or hypo, it will lead to disease. So as a clinician, we must have always think about the spectrum as a whole. The endocrine function work in integrated axis, because some metabolic reaction are maintained by many hormones, not in isolation. Like for glucose metabolism, we have insulin, glucagon and many other hormones as well. The feedback loops, either positive or negative, are the key to diagnose and interpretation of the disease. At last, understanding hormone is the key to understand the language of physiological balance and also decoding many clinical mysteries. Thank you.